Actually, now. Okay, I thought I would keep it on until we actually started the meeting, so I can see. Do I need to remember? Yeah. How are you? Yeah, I got How are you? Good. Good morning, everyone. I think we'll go ahead and get started. It's wonderful to have the problem of needing more chairs, so that's fantastic. We're glad you're all here with us, and there are several on the phone who are joining us virtually as well, so good morning. We have found that between trying to do the meeting virtually and do the meeting in person, that we can't achieve everything screen-wise unless I show you the slides this way. So forgive the little stuff on the side. This is the best we can do today. But here's our agenda for this morning. So we'll do some introductions really quick. Please feel free to help yourself. If any of you are in the 30-minute parking
phone by any chance, they've noticed there's cars in there, they will tow after 30 minutes, so they've asked that people move your car if you are there. I don't want to embarrass you. If you are, you can sneak out that back door. Is this that first row, like, close to the building? I think so.
We didn't notice it because there's like a flag for like a crosswalk flag that was covering.
Yeah, I parked there for
forbidden parking. Yeah.
Okay.
No, thank you. Okay. So don't get towed. That's not what we want today. Okay, so we'll do some quick introductions here in just a second. By all means, grab something to eat. There's lots of food and beverages, and we'll do a few housekeeping and other notifications, and then we'll get into our brainstorming time, which is great that it happens at the start because we lose Gina, who is our vital resource, around 9, I believe. And then we've got a couple of representatives from Primary Children's Hospital who are going to talk with us, Rachel really briefly, and then Tamara Atala a little bit later. And then we've got an update to give you on some other behavioral health projects that are going on, and then we'll wrap it up. So let's get started with introductions. I'm Mindy Tueller, and most of you know me. I manage the medical health portal, and I facilitate this meeting. And then, who should I pick on today? I'll pick on Dave.
Hi, I'm Kate. I'm a pediatric care manager with Healthy You Medicaid.
My name is Adam. I'm a care guide at Solid Pediatrics.
I'm Gabby Revolution. I am working in also being in unlimited.
I'm Heather Carlson. I work for Children with Special Health Needs, the integrated program.
And I'm Sonia Estrada. I work with Children with Special Health Needs, the integrated program.
On the with Healthy You.
I'm Shannon Tilly.
I'm Kim Newman. I am a care coordinator with Health Bureau.
Mika Kalnight. I'm a pediatric staff.
Hi, Kim Bloom from UCCCN. Rachel Glauber, project
manager. Children's Special Health Care Needs Integrated Services. For us on his
taking with the medical health portal resources.
Care coordinator at the university. Our customers will be able to use
And then on the line, we have a few people. Do you guys want to introduce yourselves too?
My name is Debbie Moore. I'm a care manager with Select Health.
Good morning, Debbie.
And Mindy Butters, Utah Valley Pediatrics Care Coordinator.
Good morning.
I'm Melinda Toole, Utah Valley Pediatrics Care Coordinator.
Good morning.
I'm Jenna Dilworth from Wasatch Pediatrics, I'm a care coordinator.
Good morning, Jenna. Is that it? Okay. So you guys on the phone, if you have questions or comments today, we might need to just try and speak into whatever mic you have a little bit more clearly and loudly. We're just having a little trouble hearing you. I hope you're hearing us okay. And you can certainly type in the chat. We've got Gabby watching the chat. Great, wonderful. All right, so a couple housekeeping things. I wanted to say thank you to those newer members of the Utah Children's Care Coordination Network to whom we sent a survey request, and many of you filled those out, so we really appreciate that. Everyone should have seen that link. If you haven't, you can certainly let us know, because we know you all love surveys and you want to fill this one out. Fortunately, it's not very long. What it does is help us understand kind of where you're at with your office and your own personal set of skills and experience in terms of care coordination. And that's helping us to look toward next year and determine kind of what our curriculum will be, the kind of presenters that we'll bring in, the kinds of things that we'll try and work on that we hope will be beneficial to you. Also, we have talked a little bit in the past about trying to put together some kind of online way to be able to be connected in between these meetings. So if you have questions about a case, if you are looking for a first type of thing that you're not aware of and you want to reach out to the entire group, what we found is the listserv wasn't actually getting utilized quite in the way that we thought it could. And that's great. So now we know that that's not the vehicle by which people want to do that. So we're going to try something else. And in the true spirit of quality improvement, if this doesn't work, we'll continue to try something else. So it's a forum which allows, well, actually, I'll go through it. I won't show you here, but what we'll do is send you information on how to log in and begin to use it, some basic instructions on that. But it will include a calendar, so you can always see when the next UCCCN meeting will be. It has to do messaging, so you can set your own account up to receive messages. A little bit of background noise that we're getting from someone who's on the remote connection. So if you guys maybe mute yourselves until you want to speak, that would be super helpful. And then also this forum will allow that, kind of topics that someone can post and then people can respond to, and those can be, you can go back to those at a later time. They can be archived and then searched for, and that way if you have great answers to a burning question, you can go back to the forum and look for some help there. And of course, we'll be looking to gain information from those things as well. So watch for that. Information will be coming out on that. Here's what it looks like. It's not very pretty. I'm working on that. And then we're really excited to let you know of something that many of you have been hearing about for a long time, that the ability to create custom service provider lists on the medical portal is live. It's available. And you do need to get an account, which is very simple as clicking our sign-in button at the bottom of the page. And then your first step would then be to register with an email address. And once you've done that, you get your typical kind of check your email, link to the email you received, and then your account is activated. You can set up a password and do some management in there. And then you'll get to this screen, which is your welcome screen, and that's where you can start to create your custom lists and share those with other people, make copies of those, create PDFs or prints from those, et cetera, et cetera. And so we'll probably take a little bit of time in our December meeting to go into this in a little bit more detail. Again, I'll send out some instructions that you'll see in the next coming days. If you have any questions at all, we're delighted to help you with those. And we would love, love, love your feedback, because this is a real basic set of features with this right now that we're going to continue to improve, and the best way to do that is with your feedback. So we want this to be a tool that is helpful to you. All right. Dusty, great. So Dusty asked me if she could mention something really quickly this morning. So Dusty, it's yours.
Okay. There is a camp for kids with bowel and bladder issues. So kids with fatigue, kids with Vaters, I don't know, any number of conditions. There's a whole bunch of listed here. But this organization offers scholarships that include travel and lodging, and the camp fees for these kids and families. All the counselors there also have similar issues, and so it is just a very comprehensive camp for these kids that are dealing with things that their peers are not. There's also nursing on staff, so if the kids need help with anything, they have that help available. I have a patient who has been to this camp. The patient and his mother just think it is fabulous because, like I said, nobody else in this school is dealing with these kinds of issues. And one of the parents in my practice is also one of the counselors at the camp. So I sent her phone number to you right now. So if you could include that in an email, and then if everybody wants to just take one of these, and I'll just start them down here and maybe we'll do that. That's the first one. And you're welcome to call this parent at any time and ask her questions. She would actually love it if people would call and ask questions. anyway, and so she can expand on, any questions you may have.
Great, well, thank you. I'll just ask one quick question. Is it like a summer camp?
It is.
Okay.
This was in July this
Okay.
year, and it takes place at different places throughout the country each year, so they change locations.
I see. Okay, wonderful.
Talk to you.
Okay. Wow, very cool. Well, thank you, Dusty. We really appreciate that. Okay, so this is our opportunity to do some brainstorming. Where'd Gina go? I told them that you have to leave, so we need to do this quick before you, our main important know all things person, has to go.
Okay. I count on everybody else. I do have one announcement though, as I just checked, and we've got permissions that we can be over there the next time. The prices like that. So
Oh, really? Oh, that's wonderful. That's nice. So, so we won't have to be so cramped next meeting. We can be in the bigger room over here. So, thank you. That's great news. The next meeting is December, and we're going to have some fun. So we want to make sure we can relax and spread out. Very good. Okay. So, does anybody have any anything that's going on right now that they'd like to talk about and maybe get some help with? Any cases that are causing you grief?
I'm going to throw Tony under the bus for a minute, but not necessarily a grief issue, but Tony was able to help orchestrate some vision care for a patient. So, Tony, do you mind kind of talking about that a little bit?
With Vision USA?
Yes.
So I just went into their website, and it turns out that you have to be approved by them to be like a referring agency. They only have so many, and so I filled out the application. It was really easy to do, and then sent it. They responded with an email saying that we were approved. They just want, they're asking for like your website, your phone number, stuff like that, because they want to make sure that your program is legit.
Sure. Yeah.
So we got an email saying that we were approved, and now we can go into, they sent us our own link. So now to refer patients, we just go into that link, fill out a quick application, and then if they respond and say, if they've been approved or not, and then they tell you where the patient can go to get their free eye exam.
Oh my gosh.
So they'll send us a list, and then we can make an appointment.
Wow. So is there a limited number of organizations they would approve as
It didn't
referrers?
seem like it, so any organization can apply for it, and and as long as they're legitimate, I guess will be approved.
Okay. So you're at the beginning point of this with this particular family and child.
So I just received the email yesterday, so I sent in the application, so I'm just waiting to hear back, and they'll send me the list of providers in our area that they can go and see and get that done, and I think I print out like a voucher or something like that, and take that into this place, and
So the provider can take the voucher and get reimbursed.
Yep.
And do you have a sense of how many providers there would be in a given area, in the Ogden area, for instance?
No, right now, it looks like in the Ogden area there was only one in Head Start and 2 at Midtown Community Health Clinic, and so we would be like the 4th. But in some cities there were more, so I don't think there's
Overuse.
An overuse. It just depends on who wants to start doing it.
Who's aware of it?
Yeah.
I guess I was also curious about how many vision providers.
Oh, I have no idea.
You haven't seen that. They don't publish that at all. Okay.
No.
But in theory, there'd be at least one.
Yeah.
Yeah, that's great. Okay.
This is kind of along the lines of like a donated dental type of thing that providers donate time or their facility. The one thing I wasn't sure, and I didn't read enough, is what about actually getting glasses or anything like that? I mean, I know they could be
So I kind of felt like it was maybe a part of that too. I think it just depends on who we're going to go see, and then we'll just kind of go from there. But I was under the impression it was, the exam and classes.
So it looks like they're not going to do contacts, but eyewear may be provided at no cost or for a small fee. Is so,
And is it for just uninsured patients or insured patients?
I think uninsured and have to be a resident, a citizen or a resident of the United States. And then there's like an income qualification, but they're not asking for proof of that. They're just saying you are going to make sure that that's, you're not going to overuse your vouchers that are available to the agency.
So the referral agency acts as that sort of checkpoint for these things?
Yeah, so so it's, it's up to us to not overuse it or misuse it.
So in keeping with the eyeglass theme, I want to throw one more place out there. I don't know if you guys have heard of it, but it is an online eyeglass ordering place called Zenny Optical. It's a Chinese group, but they do inexpensive glasses and they ship them really quickly. I can't tell you how many times I've had families say, they gave paper pair of glasses for my kid, and 5 days later they're destroyed. And so they're not going to pay for another pair. But the thing that's nice about them is, glasses, you can get a complete set with, frame and the lenses for about $30. They even have some that's inexpensive as $6.95. And if you order one pair or 50 pairs, it's only $5 to ship them all to you. They don't require necessarily a validated, a lot of online places want a prescription from your provider. They ask you to put the prescription in. So if this is somebody who has an eye exam and a current prescription, they can put that all in and it gives you all sorts of different options to be able to buy inexpensive glasses online. For my family, we've used them for years.
Really?
Are you wearing it?
Right here. $20, guys, $20. The same. So, and some of them aren't stellar. I mean, it's a crapshoot, but it does give you a way to enter your picture on there, so you can try some on virtually and some things like that. So, it's kind of been it's going to sound funny. They've gotten more expensive over the years. It used to be like you had $7 glasses, $10 glasses, $15 glasses, and you would be like, ooh, gosh, do I like those $10 ones more than those $7 ones? It makes you real cheapskate. The prices have gone up just a little bit since then. But when you're looking, last time I was in like a Lens Crafters, I was looking $350, $400 for just single vision glasses. So it's a big savings, and it might be an option to offer to some families who might be on limited income, who may have a prescription and just need to pick up a few extra glasses. Again, it's hit or miss, but for the most part, I've been relatively happy with the quality that I'm getting.
Cool. Okay. That's a wonderful resource. We'll make sure that both of those are in the portal database if they're not already.
And they have sunglasses too.
Really? Okay. All right. Very good. Okay. Anybody else? Did that spark some thoughts? Anybody else want to bring anything up? Really appreciate the new resources, the new things that you guys tell us about.
There cannot be added to the new resources.
Yep. All right. Okay. Well, with that, we'll turn time over to Rachel for a few minutes. And Rachel's going to talk about it's an update on something that she about.
Yeah. So wherever you like. Yeah.
So I don't know if some of you have heard about navigator scheduling and how scheduling for we did some research. We had a nurse, for myself, that was part of the program, along with the scheduler. And when we did the research for it, found that it was just more useful to have parents, families, healthcare professionals just call straight directly to the scheduler instead of through me. So they have removed me from this portion of it, and it's now called coordinated scheduling. I brought this, and I'll tell you how to use it, and the direct number to the scheduler to help you make the appointment. So 3 or more appointments for kids who need special kind of services. you about the email, so put your names in, so we'll give you updates as we go along and do research for that. So if you want one of these, let's start have that as a resource for your families. Any questions?
Most of the time when I run into the coordinated scheduling and when applications is going to go in for any number of procedures, like, and we can coordinate imaging or other procedures to go along with that. So they can help with that.
And so what you need to have like an order next with it, the physician that wants, or whatever, along with your record, you make sure the order is sent to you at the request.
And it doesn't have to be like more than 3 or...
Right now, yes, because we don't have a staff for it, but we're tracking it, so as it increases, we'll be able to get more staff.
What is the wait time currently? And then
It depends on the physician's schedule. Tasha is the scheduler there, and she would be able to tell you the wait time. So it'll specifically go straight to her, and she can tell you, because she has access to all the calendars.
If the procedures and surgeries aren't needed here, is that still happening like through some of these business departments? Kind of like
Yes.
we would have a kid at Andrea PTA for ophthalmology, so we would try to get gastroenterology or somebody in some work time. So they just they'll just working those departments.
Yes, and I think that they will eventually look at how we can do that same thing, if it's not there yet.
Well, that's wonderful. Okay. For those of you on the phone, we'll scan the handout and send it along in the email, so you'll have that as well. But that's I think good news. I know that Primary Children's is working really hard on trying to improve the coordination that they do within the hospital, within their clinics, within their sites, and then hopefully that'll reach outside as well as it is through this model already. So yeah, that's one thing. All right. Unless my eyes deceive me, I don't think we have our other presenter. Hope that we didn't confuse him on the location. So I will skip down a little bit and talk with you about some of these other things that we wanted to bring up. Because today is supposed to be kind of focusing a little bit on behavioral health. So services, places you can send your families and children, and also so that you can be aware of what's just generally going on in terms of behavioral health. So we may have alluded to this before. It's going to be a bit of a departure from kind of those on the ground things that we've just been talking about. So every state has the opportunity to get a grant from the federal government called a state implementation grant. So a state implementation model is what I think it stands for. I'm not sure why that's popping out there. So that's what SIM stands for. So the SIM grant, we're in a stage of that particular funding stream where it's planning only. Other states are in they're in the implementation mode. So we're in a planning mode. And so we're currently, I think, a couple of months into this. And the Medical Home Portal and UCCCN team are actually heading up one of the main pieces of the planning, and that's around behavioral health and primary care integration. So it's not a doing grant. We're told that all the time. Only plan. So what we get to do within that period of time is to do a literature review, to look at what other states are doing in terms of integrating those things. And in fact, there are plenty of other states who have embarked on this to quite a degree, and in some cases are quite successful. There's also trying to understand what a true inventory of behavioral health providers would do, and that's me. And also we'll be doing focus groups and key informant interviews as well. So it's exciting in that we're beginning to see what can work, what could work. We're meeting with all the various groups within Utah who are relevant to this effort. So we've got a close relationship with the Division of Substance Abuse and Mental Health. And we're excited at what the opportunities and possibilities are because there's a lot going on already, and that's part of what we're learning through this so that we don't duplicate efforts. One of the things that you may or may not be aware of is that the Division of Substance Abuse and Mental Health, who oversee all the local mental health authorities. They are working with 11 of the 13 mental health authorities. So those show up sometimes in individual counties if they're bigger, so Salt Lake County, or in other counties they're kind of grouped based on geography and population size. So there might be 4 or 5 counties grouped in a mental health authority. And they're working with the schools. They actually have integrated counselors right in the schools, which has been quite successful. So the idea there is that you're in the place where the child is, and maybe the child is showing and displaying those behavior problems. And when mom and dad need to be a part of that, team approach, they don't have to go to the school, pick up the child, go to the provider, go through the visit, take the kid back, because in many cases that will, that'll be the straw that breaks the camel's back. They won't take that time and do it. And there are other reasons that is a barrier as well. So this is breaking down barriers, and it's been very successful. It does require legislative funding, and so they're working to show that it's been a success and had good outcomes. So that's something that's exciting. We're also definitely looking at things like telehealth opportunities in this as well, which is an exciting area, and it's definitely happening in other places to a larger degree than what we're doing here to some degree, and so we're excited about that. So in my area, what we're trying to do is understand the issues are to do a true behavioral health inventory. And so if you guys you need to know what we want from each provider in terms of information, and some of those things are more obvious than others, but that's where your input would be very helpful. We know that one of the main things that would be useful there would be payment and insurance information, and that's probably one of our biggest barriers to any kind of provider inventory, as you can imagine. But we are excited that there might be some opportunities to work with payers and get that information direct from them. So the climate is right, and I just wanted to pass along that kind of exciting news to you that this is a big effort. It's something that is funded through the federal government. It's being looked at a state level. So we hope to have some positive news and hopefully more funding at the end of this and let you know about it. All right, so Tamara is here, so I'll actually turn the time to him and go back to his slides.
I think some of the phone calling you is trying to talk.
Oh, Gabby, can you see that?
If you're wrong, maybe I'm wrong. No. Okay.
Okay. So I got you through a maze.
Great.
You want to sneak through that way?
I think I can manage it, yeah.
Good morning, how are you?
Good.
Steve, I can come this way and I'll step over here. I was telling everyone before you arrived that we don't have the slideshow view here because it doesn't work with our remote recording. So if you don't mind just advancing the slides. There we go. Okay.
Perfect.
All right, great.
And let me go ahead and also pass these out. If I don't have enough, I'll send them electronically to get them forwarded. So my name is Cam. Is there a mic or anything I have to worry about, or is this the mic essentially? So my name is Tamara Atala. I'm the Administrative Director over at Behavioral Health for Primary Children. And what I wanted to do today, other than just simply go through a quick review of our programs, I thought I'd take a few minutes and actually share with you any provider that comes here that talks about behavioral health will likely tell you a handful of things. The first thing they're going to tell you is that access to behavioral health services is horrible, regardless of who the funder is, regardless of what. And so what oftentimes happens, particularly in the role of a care coordinator, is you're always trying to seek information about what new is coming, what other program is available, what funding stream goes to what program. It's a highly fragmented system in this state. So I want to just share that, because for all the programs that might come here and talk about their programming, they're going to talk about access challenges. They're going to talk about where to find services that meet families' needs. There's going to be a lot of those types of questions. They're going to try to present solutions to those problems. And the fact of the matter is we're also facing some system challenges as well that I wanted to kind of share and lay the groundwork before we actually talk about programs. Because I think it's been interesting to me to think about this problem and then share what our programs are, and then also talk a little bit more detail about why, what changes we're trying to make in order to be effective. So a couple questions that you definitely want to ask as you move forward and speaks to the challenges that we have is, I would challenge you all to not just ask for what mental health services are available, but rather, what is the actual content of the mental health services are they actually delivering? So for example, don't ask people whether they have outpatient services or not. Ask them what the evidence-based practices they're using within those programs. Services are not created equal in this state. They're not created equal. And so you'll wonder why a child may fail in one particular outpatient program and succeed in another. And so it's important to not get caught up with the child fails in a particular program at a particular level of care, but rather what's going on in that program that would leverage and make you think about what's the best fit. Because they could be in one outpatient program and go right next door to the next outpatient program and have enormous success. So I just want to highlight that as you start to think about how to coordinate care. I also want to share a little bit about the challenges. And so I'm going to, this slide, first of all, how many here are aware of the SHARP survey? So for those that don't know, there's a few hands that went up. For those that don't know, we're very lucky in Utah where we have funding that has been available since 2003 to provide actual screening to 6th, 8th, 10th, and 12th graders throughout the state of Utah. We've got about 55,000, and this is through the work of the state of Utah, and I should also add, there are about 300 and some odd questions these poor kids have got to fill out, usually during a particular series. This usually happens every other year. The area I want to highlight, there are a set of questions that identify what is the actual mental health need in, based on kids' response, so based on 6th, 8th, 10th, and 12th grade. And I want to highlight this lighter gray over here, that's 2011, 2013, and then the most recent survey outcome is 2015. Of the kids that reported in 10th grade, over 20% of them indicated based on their responses that they actually would need mental health services. 20%. I mean, that's huge. I mean, I know we talk about 1 in 4 and 1 in 5, but these numbers substantiate that, I think, and the concern that I have is it's getting worse. So think about that. So problems are sort of beginning to increase and beginning to get worse. The next challenge gets even more serious. We're talking about suicidal ideation. So again, 6th, 8th, 10th, 12th graders. The bottom, the first tier here talks about have actually considered suicide in the past 12 months. 20% of 10th graders have had actual thoughts about committing suicide. To take it a step further, and we oftentimes, in the mental health world, we oftentimes think of suicide in terms of acuity. There's one thing about having a thought, there's another thing about having a plan, and there's a third thing about having an attempt. And that tells you what acuity means. So as I walk down over here, how many have actually made a suicide plan? In other words, a specific plan of how they're going to kill themselves. Of the people that responded, the kiddos that responded, can you see the change between 2011 to 2015? Between 8th, we're talking, somewhere from the 8th graders, we're talking, when we talk about 8th graders, we're talking about 13, 14-year-olds, that 8% of them have actually made plans in 2011. Now it's above 13%. 10th graders are above 15% now, where they started under 10%. And that's of the general population. This isn't a specific subpopulation. This is the general population. And the third, so you can see how the acuity gets more and more, have actually made attempts at killing themselves. 10% of those of 10th graders reported that they actually made an attempt. So those are stark numbers, and you can see how they're all increasing. So I kind of find myself asking the question, well, why is that happening? Why are kids? Why over the years are kids becoming more and more? There's a greater need for challenges because the population has only increased, generally speaking, over a period of time. We're talking less than 2%. So why is that happening? Why are these numbers going up? To validate this a little further, this number is when the slideshow is running, I apologize for this, but what this shares is at primary children in the ED, in the emergency department, throughout the hospital, these are actually the number per month of actual crisis evaluations done at the hospital. And what I want you to note is in 2010, the average in 2010 was a little over 50 per month. Right now, we're running just shy, on an average, coming through this year, around 70. Now, I want to highlight, the reason why I highlight this in terms of each month, this is per month, and this is sort of average per year. So this is like a rolling average. And the reason why I want to highlight that, you can actually see how seasonal it is. So we're going to have a lot of kiddos that are at risk and require a crisis evaluation, typically during the winter months. I mean, my argument has always been that all you got to do to remove suicidal risk with kids is you just keep them out of school. Because it seems like it's the only time they're really sick. But the reality is you see these sort of huge peaks that sort of come up. And so what we're projecting is from 2010 to 2020, so that's 5 years from now, we're projecting it's conservatively 2.5-fold increase. I think more realistically, because if you actually run the curve out and the way we ran the numbers, if you actually run it, it's actually getting steeper. So we're thinking it's probably going to be around 3-fold from 2010. So it's all going up. Increased demands. So I guess I pose the question to this group real quickly before I start talking about our programs, is why do you think that's happening? Why is it going up?
Well, I just want to ask you a question. And my youngest is 17 right now. Why is 10th grade higher than 12th? Because by 12th grade, you take an ACT that you've either done well or not done well on. You possibly didn't get into your first choice college or whatever. So why, that's kind of 12th grade reality. Why is 10th higher than 12th?
It's a great question. And the fact of the matter is, this is just data. There's not a reason why. So it could be the time in an individual's life where there's additional stress, because we know that environmental stress has a direct impact on someone's propensity to develop symptoms related to mental illness. So that could be part of it. But if you notice, the trend is always 10th grade is always higher, like you mentioned. Why else is that? I mean, why more recently has it gone up? If I look at the previous slide here.
Social media.
Social media. Let's talk about that for a second. This is a number to me, and again, these are all theories. We haven't fully tested this out. I mean, there's a lot of theories to talk about. This was really powerful to me. Cyberbullying. Of the kids that report, these are self-report, lifetime report. Again, 6th, 8th, 10th, 12th grade. 0 times, right? 1 time, 2 times, 4 times, or 5 times. 6 times or more than in their lifetime. I want to highlight those kiddos, 6 or more times, 50% of them report needing mental health services. Over 50% of them have considered suicide. Over 63% of them have actually experienced symptoms related to depression that would qualify for a diagnosis of depression. Now, does that mean that that's the cause of that? I don't know. I mean, there's a lot of factors, but this was a real stark example of like what are some of the contributing environmental factors that are related to this. So I want to highlight that as you're trying to develop strategies of coordinating, the other challenge that we have this huge increase in demand. And I want to add another interesting piece that I think is important. The state of Utah, over the last 3 years, has made a huge increase in early identification of mental health services. So actually people are coming through more often. The unfortunate piece is they haven't matched the funding on the provider side. So now you have more people that are actually aware of the problem, stigma's beginning to go down, and the reality is there's not enough providers, so all of you are trying to scramble to find placements, right? And if we just let this ride out, if we do everything just business as usual, what will happen is the EDs will continue, and the emergency departments will continue to get inundated, and we'll build larger and larger psychiatric inpatient units. And that's not what we want to do. But if we just keep watching this and the providers do nothing, that's what will happen. More kids will get institutionalized. Yeah?
So with early identification of mental health issues, we have a lot of kids who put into counseling really early. How does that correlate with inpatient, or does it? So if they're getting private mental health services through a private counselor, does that decrease their chance of ending up
Absolutely.
inpatient, and by what percentage?
So I don't have the numbers for that, but I can share with you an anecdote, well not an anecdote, data that talks about that may be parallel to that. So what we do know is we know that if a child, or an adult for that matter, after leaving an inpatient setting, an inpatient psychiatric setting, actually goes to another mental health provider within 7 days, their chance of going back to inpatient goes down substantially. So I think it sort of supports that idea that they need to be connected. Does that make sense? So I want to put that context in front. I'm going to really quickly, I'm not going to regurgitate the information that's in front of you, and for those that don't have it, I'll make sure that I send that out. But I'm just going to go through things quickly. So at Primary Children's, we have a full continuum of services. What I mean by continuum, I mean from sort of inpatient setting all the way to what we're going to call what Intermountain refers to as mental health integration. And there's a lot of other models out there, but I'll talk a little bit more about that in a moment. So Wasatch, so for those that don't know, Primary Children's has multiple locations outside of the hospital in the Eccles outpatient building. So Wasatch Canyons is on 5700 South and about 1500 West, and it's part of Primary Children's. People oftentimes forget about that. This is actually, you'll hear Wasatch Canyons, but it's actually part of Primary Children's. Up at the hospital, we actually have our, we have a program of very, very talented triple board psychiatrists. So those are psychiatrists that are boarded or have their boards in adult psychiatry, child psychiatry, and also pediatricians. And they are up at the hospital, and they provide psychiatric consult liaison services. They're actually embedded into the hospital to provide services for those kiddos that are in the hospital that need mental health services, and do some consultation of those sorts of things, in addition to crisis evaluations. When I say crisis evaluations, typically that has to do with kids that are acutely suicidal or become suicidal and need to be evaluated to determine whether they need inpatient services or not. So having said that, I wanted, what's attached to that consult liaison service is in our Eccles outpatient building called Pediatric Behavioral Health. And what Pediatric Behavioral Health does is they're very unique in that I don't think there's anything like in the state where they actually work with kids with chronic illness of different sorts, but the behavioral health symptoms are really getting away from them to manage their physical health, which is going to be over a lot of that kids. Now here's the dilemma: it's a really small clinic, so access and they're very, very unique in that environment. So they know how to work in those sort of environments. In addition, I should also add, and this campus is a pretty broad campus. There's plenty of different buildings. It's got a huge lawn. It's a really neat campus if you've ever been on it. It's kind of a spread out amongst a bunch of cottages. And so as we move into our Wasatch Canyon campus, unlike other hospitals, the inpatient psychiatric unit is actually out here. It's not in the hospital. So we do that on purpose. We actually pull it out of the hospital. The reason why we do that is we have the rest of the continuum out here. 90% of our services are actually out here. So it's a 20-bed inpatient psychiatric unit, but what will oftentimes happen is if a kiddo is struggling in our outpatient clinic, we can just walk them over to the inpatient clinic right there, unless they need to be medically cleared. And we have that happen. I wouldn't call it often, but it's pretty regular. As you step down, we have two sets of programs. Think of it as an adolescent kind of subspecialty program and a child, sort of your 5 to 12, maybe lower functioning kiddos that are 13, 14, that are a child residential and day treatment program. Those programs are throughout the day. Now, I should add, let me take a step back, because of this interesting environment we're in, Primary Children's for behavioral health and only behavioral health, with a few exceptions, doesn't take Medicaid. Nothing like trying, but we don't. So the only exception to that is pediatric behavioral health and one other program in the hospital for behavioral health specifically. So we have our residential programs. And so what's great about that is they oftentimes will step down or step up if need be. You know, those programs. These kiddos have a huge amount of, I would say, well over 50 struggle with trauma. So a lot of these symptoms are targeted around trauma and those sorts of things. So that's our child program. In addition to that, we also have an adolescent program. The adolescent program is sort of in 4 buckets. So it's one program, adolescent psychiatry residential program, adolescent day treatment psychiatric program, and then also we have a substance abuse programming that's also residential day treatment. It's in the same program, so it can really be customized. Because in the residential program for substance abuse, I would say all of those kids have comorbid mental health disorders, and then typically that's it. If you step down as well, we also have our outpatient clinic. And our outpatient clinic is a pretty large clinic. I want to say there's 14 therapists, and as is a challenge across our system, 3 medical providers. We take in about 100 kids who come through a day in the clinic, so it's fairly busy, and those just come to this clinic. So we really have 2 outpatient clinics. So, as I said before, if we continue to do the same things over and over again, we would expect, unfortunately, this increase our inpatient unit. What we're doing, however, is we're talking about developing services a little bit differently. So our focus is rather on trying to build a larger inpatient unit, we're actually trying to resource more upstream, meaning into primary care. So many of you may be aware of this, and we talk a lot about primary care mental health integration. But mental health integration within Intermountain is a very specific model that really focuses on providing pediatricians with additional knowledge about how to provide mild to moderate care for behavioral health issues. And the reason why we do that is because the number of psychiatrists we actually need in this state, we'd have to clear out the East Coast and bring them here. There just simply isn't enough. There just isn't. So we have to find a way. And so what we do is we have a consultative model where they're physically in the clinic 1 day a week, but they're also providing a ton of training to that team. And they have a way of stratifying the degree of behavioral health challenges from mild, moderate, to severe. And those severe cases or tertiary cases get funneled back to our clinics. So the idea for us is we started to expand about a year ago into mental health clinics. And so what's nice about that, we have one of our team members that actually physically, we have more than one that goes out to these clinics in Southbridge, Mountain View, Memorial, Holiday, Sandy. One should be rolling out in Kearns in December. Our goal is to continue to bring out about 10 clinicians a year into primary care settings. So we're actually providing a broader access point. So the access point is actually primary care rather than the ED. Because right now, the main way to get the primary mechanism, if you want to get mental health services, unfortunately, really fast, you go to the emergency room. And we also train mental health providers when kids are suicidal to send them to the ED. And the fact of the matter is they don't need to. In addition to that, our day treatment program actually has a fully certified, as well as our residential program, has a fully licensed school in there. But what we also recognize, that's a huge disruption for the kids. And so what we're in the process of building right now is an intensive outpatient program. So think about that as almost as an after-school program. That fits in that group. But the key to treatment, and this is really tough on families, if you actually want to have any change with kiddos, the only way to do it, I mean the only way to do it, is you have to have high family involvement. There's no data that suggests providing groups. There's some exceptions, but very, very, very few. We're actually treatment, there's no evidence that suggests that parents aren't on board and understand what's happening. The chance of them having a positive outcome is really, really low. So our goal is to develop outpatient programming to focus on anxiety, depression with child and adolescents. We're talking about building potentially daycare for some of the kiddos so that we can actually work with the families as well as the kids during that period of time. And we also have, for those that may or may not be aware of this, DBT, dialectical behavioral therapy for adolescents. those that don't know, these are for kiddos that really are constantly, they just have difficult time regulating their emotions, and so, you know, they're threatening to kill themselves weekly. They're just really just unable to manage their emotional state. So we're going to have an intensive outpatient program there as well. So that, in summary, and I'll leave sort of the last 7 minutes for questions, is sort of what we're trying to accomplish. We're trying to, rather than sort of get pulled and drawn into the data that tells us we need to build more inpatient kind of hospitalizations, push away from that, because we actually feel that the answer is to coordinate more services. So I'm not sure if that's what you're interested in. Yes?
Sorry, I have a ton of questions.
Please do.
All day long, I swear. So we've used Wasatch Canyon for kind of a return to school for kids that are highly anxious and have school avoidance. Can you tell me a little bit about what kids are actually we should be looking into those services for? Because we get kids that they'll throw up. They're going to school and they will throw up to the point where they cannot attend school. And so, I mean, we've talked a lot about suicidal ideation and the reasons for using that. But we've also had kids with autism that end up with a lot of school avoidance because, you know, the clothes don't fit right, or we have a hard time getting them into the school. The parents have a hard time getting them into the school. Can you talk a little bit about how the outpatient program?
So anxiety, I mean, that's a very common occurrence where kiddos experience such significant anxiety that they actually develop physiological symptoms that can be very degree. So in terms of anxiety, I mean, a lot of this has to do with, there's a lot of options. We know the best option, depending on functionality. So, for example, adolescents. So anyone that's talking essentially kind of a higher functioning 10 or 11-year-old through adolescence. What we know is incredibly effective is cognitive behavioral therapy, perhaps with medication management. Now we would like to try the former rather than jump into the latter. Oftentimes parents don't have the time to do that. But that's what best practice is. For those kiddos that may struggle with different social triggers, such as autism, the challenge is really doing more behavioral analysis of sort of what are their triggers and understanding that a lot of it has to do with home structuring. There are very, very few indications for psychotropic medications for autism, although we know that it's being used a lot to manage those emotions, to manage emotional states. I would argue, and the challenge is, if you talked about, I talked about mental health services being fragmented, autism services is even worse because no one owns it. Mental health doesn't own it. I mean, they sort of do. Developmental disability doesn't really own it, but they have that. So no one really owns it, and so there's a lot of effort right now at Intermountain about it. And then also pediatrics. Pediatrics doesn't know what to do with it. And so it's even more fragmented. So the challenges you speak to are very, very real, and it really becomes a hit or miss, like who's good at doing this. And for example, I know I have a couple clinicians, that's what they specialize in. That's what they do. They do a lot of testing to figure out what their triggers are. They do a lot of both psychological and also doing the ADOS and other testing to kind of see, so what can we set up that might work? Because literally with autism spectrum disorder, it's unfortunate that we bucket it in one group because it is truly a spectrum. There is no one-size-fits any autistic kid, in my view, because it's just even a broader spectrum. So I know it's not a great answer, but I think it's just that's the reality we're struggling in terms of how we're trying to manage it.
Sorry, that kind of brings me to a follow-up question. I'm going to talk all the time, you guys. I'm sorry. So let's say I do have a kiddo with autism that's dealing with school avoidance issues and things like that. What questions should I be asking of our local therapists to see if they are appropriate to provide treatment for these kids?
Well, very simple question I would ask at the beginning. Talk to me about your training and working with autistic kids. And what I'd be interested in seeing from them is, are they aware of understanding barriers to their ability to socialize? So, for example, not just oftentimes we think of autism in one plane, behavioral, and I think it's important to ask them questions related to what do they know from a resource perspective about, do they know what communication skills, for example, are barriers to them contributing to their autism? Are there Are there, for example, we use occupational therapists a great deal to help inform our therapists about tactile issues that tend to come up with these kiddos a lot. So the things I'd be asking for is what resources do they look at to assess the situation? And so that's why you'll find a therapist that says, yes, I'm really good with autism, but if they only do behavioral strategies, it's going to work with a small handful of kids because you're not looking at all the dimensions. So, and then unfortunately we say, yeah, outpatient, we tried, that didn't work. When in reality, it may have worked with the right set of skills. So, one of the things I didn't add here that we're really pushing through is, unfortunately, there's a great deal of evidence of things that we can do in a real controlled manner to really have positive outcomes. The problem is because each child is so unique, you have to vary from those evidence-based practices a little bit. So the reality is that's why you have a lot of hit and miss different clinicians and different providers. And so be cautious about that, but also just ask the questions. So for example, the question you're posing to me is an excellent question you want to be asking to the provider who's going to be delivering services. Don't just assume that if they have a license, an LCSW, or a PhD, that they're going to be good at treating your child.
Yeah, you had said that there was a small exception to the not accepting Medicaid. What is that?
So pediatrics. So we were able to get so in Salt Lake County, Optum Health is the contracted provider for behavioral health, and Primary Children's has, from the behavioral health side, we've made a small contractual agreement to work with our pediatric behavioral health clinic that's up at Eccles that specializes in chronic physical illness with behavioral health problems. So we treat those in that environment. The other cohort that doesn't fall under my portfolio, but we work with closely, those that may not be aware, is Safe and Healthy Families that works with children that have experienced abuse and neglect. So those are the two.
We are fully integrated at the County Student Mountain View. We have a psychiatrist that comes every other week for parents who live in the LCSW. But the LCSW is not familiar with very good at. And one thing that I've learned from him as a therapist is he's really good at interacting with the schools. So if you have a kid at school waiting, he is incredibly good at interacting with the schools to make sure that he is working on the same things that the school psychologist is and that they have the same plan in place. And so I started to tell people, because not everybody in our clinic are in medicine. When you call ask if the therapist is willing to work with the school, not all therapists are, but that's really around the normal with interaction with the school, or our interaction with the school, so if we can find out for them what their plan is, we can interact with them.
And I'll just piggyback on that because I think that's really, really important. Somebody brought this up and it was like a light bulb going on for me. So with primary, they're doing a lot of this integrated stuff already between primary care and behavioral health, right? But if you're not in a position with the particular family for that, to go to that resource, and you've got to help coordinate between primary care, behavioral health, and the school now, that's a question to ask the potential mental health provider. Are you willing to coordinate us, primary care, and the school? So I think that's really important. I mean, we know how hard that can be, but if they're not, that breakdown in communication can be the difference between them working and so I think it's a really, really important question.
And those are expanding, so I think another follow-up question to ask primary care practices is, do you have plans over the next year or two to have integration? Because that might change the way you strategically plan how you coordinate care. And I should add, these clinics have an evolution of their own. So each clinic evolves differently from clinic to clinic to clinic. So when we bring our cohort of mental health therapists together, they experience very different experiences from primary care clinic to clinic. So just like schools, all primary care clinics have their own personality, and it's just the ability of that group to develop a team as well. I think that's all the time I have. No, please.
Where do you get the therapists for these clinics?
That's a great question. So we have made a strategic shift in working with the medical group at Intermountain that we hire all of the therapists so they're part of our department, and then we actually deploy them to medical group for 1 or 2 days a week. And that way they're part of our department. They get all of our evidence-based training. They also know the programs. They can refer really easily in there. Previously, they actually, I believe, the clinic used to hire their own, or the mental health integration group out of medical groups. That's how we do it.
So then, is there any way to actually part of this, like, podcast or little pediatrics, like, that's something that so it's got clinics into this?
All the time, all the time. So I work with, and if you want to, I can chat with you a little more about that later if you have time, but what we have is, I work with a strategic group at the medical group, and they have sort of per primary care practice, they have sort of a readiness checklist. They've done this, I should add, they've done this for over 15 years. So they've had a lot of great successes with clinics and some that required more effort to kind of help support. And so they sort of have a checklist of sort of readiness. And then once they kind of determine that the clinic's ready, then they deploy someone in, make sure that the provider has education about the mental health integration model, make sure there's a physician champion at that particular location. So there's a lot of elements that need to go into place that, like for example, I work really closely with Joe Macy in the medical group to help us coordinate that distance in the Salt Lake area. Salt Lake and Broad.
Dr. Nodding, who's on the line has a question. So what questions the family or a clinician at the time asked the best a behavioral health provider, and how would they evaluate the responses?
That's a great question. So first, it just starts as simple as tell me about your background. What have you experienced before in behavioral health? Try to get them to focus on specifics. If you know that your child, for example, is struggling with anxiety, ask them what is, tell me how you work with kids that struggle with anxiety. Ask them a question about what's your experience. This is a really important one. Ask them their experience about working with families. You'd be surprised to see the number of clinicians that don't engage families very often.
Also ask, are there key responses to look for or to run away from?
I think the key responses are they going to engage the family? And do they also have a good resource network? So for example, the area that I'm most concerned about from a clinician's perspective, typically it's not the clinician at all. I also had the privilege many years ago of working, I chaired the Doppel board for social workers. And what I found is the practitioners that were least successful were oftentimes isolated. They were in their own private practice, had their own shingle, they were by themselves, and they didn't have a peer group to sort of work with. Because these cases can be really, really challenging. And when you're isolated, interestingly enough, these were all good intended people that were on probation, and they just isolated too long. Or they were in highly urban or frontier areas, and they didn't actively engage to connect with people from abroad to make sure that they had a network of talking about difficult cases. So it's those environments. I wouldn't argue that they're bad clinicians, but they've set themselves up for a really difficult circumstance. I don't know if that answers this question, but please.
I have a question. Don't worry about time.
Okay. All right.
You have the time.
No, I've got time. I just want to be sensitive about it.
No, you're good. So what kind of trauma training do primary children?
So Safe and Healthy Families is actually has certified trauma-focused cognitive behavioral therapists there. We have intermittent, in Wasatch County, we have some intermittently trained folks. Our plan is over 2016, we'll have all of our clinicians that are actually trained. And the training is not just training time, but it's also consultation over a period of time, so we're very excited about that. I also just recently hired an individual by the name of Brian Miller, who came from the Children's Center, who's actually a trainer in trauma-informed and trauma evidence-based practices. So that's a big, big push for us. We're recognizing the science in that area and the number of kids that have experienced trauma in some way, shape, or form. And also, we're also being much, much more sensitive to ACEs, where we're being more attentive to what childhood experiences that have increased risk factors and what childhood experiences have increased protective factors. And so we're beginning to inform our treatment related to what the environment is and shift that from, I think, what historically has happened in our environment, which is based on interest. So the notion that we're actually going to focus on what's out there and what do we need to help with. So the stuff we're hearing a lot of is autism. We're hearing there's not an easy answer pediatrics and other cohorts as well. It's a tough one. In school too. The other area that I think we're struggling with, that we're hearing a lot of, is challenges with providing comprehensive treatment for eating disorders is really tough for us, particularly for adolescent kids. Really, really tough right now. And there's different philosophies in treatment that appear to oppose each other that's out there. So that's also difficult for them.
You started off by saying the question we should ask has to do with the content, the evidence-based content of the services.
So there's a lot of ways of asking that question. I think what it does is the question isn't specific, except that I would think of those questions as ask them how are you trained? What recent training do you have? What evidence-based practices do you use? If you know what the diagnostics are of a child, if you know and you don't have to get technical about what their diagnosis is. They've got an anxiety disorder of some sort, they've got a mood disorder of some sort. How do you talk to me about how you've informed yourself to treat this? So it could be related to that. Evidence practice right now, the reason why I bring up evidence-based practice is it's a huge buzzword in that people say it all the time, but I want to challenge our own clinicians as well as folks that, well, what does that mean to you? And when you listen to them, you will immediately gain a level of comfort, or you will also gain the desire, as was mentioned earlier, to run away. Just because, and it's not out of malice. It's just out of, what resources do they have to get the information they need? What consultative support do they have? And again, that's why we're strategically trying to make sure all of our clinicians that are deployed are connected with our department, because collectively our department has got an incredible resource of knowledge, from psychological testing to neuropsych work to excellent psychiatrists, triple board psychiatrists. So if they don't know, they can get an answer, or they can refer to someone that has that. So someone that feels comfortable doing that is really, really important, rather than this old adage that I'm just going to see them and I like them, so I'm going to continue to see them because I like them. So I don't know if that helps kind of massage that question.
So related to what you were saying, I have two questions, and they are related to another. First, in context of the fact that yes, there's some buzzwords going around, it's very clear in the national dialogue about mental health and looking at how you approach that includes outcomes. Right? So how is embedding in primary care, how are you strategizing to come up with outcomes that are meaningful, and the recovery-based outcomes? And then secondarily, when you think about being in practices and wanting to refer your family, Chuck had asked a very thoughtful question. My question on top of that would be, asking if somebody's training is one thing, it's very important, and understanding if you feel comfortable with them is absolutely vital. But recognizing, are they successful? How do you determine if they've had a good success record with, whatever condition, especially if, eating disorders treatment is so challenging right now. So, you really can't get your arms around successes there, but maybe in another area. So I'm wondering what the strategic plans are there. Are you having group development of outcomes to think about?
So those are, I think that's great. So let me see if I can answer the first question. So the first question is really the point that I didn't highlight. Outcomes. Not a lot of mental health practices actually use what I call sort of distal outcomes. So things like, in aggregate, I'll look at things at lowering readmission rate, and that doesn't really help the child. It helps us see if the system is working better. Primary children, our entire continuum uses a youth outcome questionnaire. It's a 64 questionnaire that we ask to do, and it's actually part of true evidence-based practice in and of itself, in addition to outcomes that we use. Therapists that know how to use it and providers that know how to use that well, families actually tend to want to fill out the 64 questionnaire because it gives them a perception of where they see their child at, as well as a self-IQ for those that are 10 and older. So we do that in all of our behavioral health clinics with primary children. And we track that in aggregate. And we look at that individually. So it's actually an individual tool to determine relative progress, and that's for the perception of the child and the family. And what's really fantastic about that is it creates great opportunity for family therapy, because if the kiddo thinks that they're completely fine, if not they're sort of superhuman, and the family still thinks that they're really, really sick, then we know where to focus. There's a dynamic gap there. We need to talk about family. That makes sense. So it does other things for us as well. So that's what we're using on in the specialty practice. I think is really important and informs improvement for not any different evidence-based strategies. The second thing within mental health integration is actually the scoring mechanism to talk about and an algorithm that talks about how we're successful in those areas. Intermount does some interesting things that I think are helpful on the aggregate, but are probably less helpful at the individual level. We actually look at, we've done multiple studies, particularly with adults, that I think are really fascinating, where those that have operated and had their primary care practice have mental health integration in them and they actually use them, the cost on the payer side, on the member side, went down significantly. So there's a cost benefit there as well. And there are assessment tools used as well. So the PHQ-9, for example, is a tool that's being used for depression. And there's other tools as well. Right now, think of it as sort of two different systems sort of trying to align to each other. Mental health integration exists in its own culture for quite a bit of time, and we're now trying to merge the two. So we're trying to leverage both of those, also being sensitive to the family, because they fill out a lot of it. So we've got to make some really difficult decisions. From someone that appreciates a lot of really good data, it's always good. I mean, at some point we've got to treat them, right? So.
Thank you so much for your
Absolutely.
time. Really. And I'll just make a quick note. If you do need to leave early, you can pay for a parking validation. So she's got those if you've got to go. So, well, that was really great, Jeff. So I wanted to follow up on a couple of things that I heard, or thought of while I was listening. So one is here. So we actually have been approached, the Medical Home Portal has been approached by some trauma-trained professionals who are very interested in trying to make sure that that kind of information is in our database, whether or not a provider in our database is trauma-trained. And there aren't as many as you'd hope, but I think with the ACEs study and a lot of that stigma starting to come down, people are beginning to understand more about how important that kind of training and understanding of a child and their family is. And so we are going to be working on getting information on trauma-trained providers into our database. So we're excited about that. So I wanted to piggyback on that. These folks that we're working with on that project have made me aware of a couple of websites, so we'll make sure that they're in the Medical Home Portal as well, where you can check what evidence there is for and this is the term I hear them using, modalities that's being used by a practitioner. So you can see what the evidence is regarding that particular kind of therapy for kids specifically. And so we'll make sure that those websites are in there as well, so that when you ask someone, what's your training? What kind of therapies do you use? You can then go and look in here and say, oh, well, that has a level 1, so I'm not necessarily going to feel comfortable about sending my family to that. Or if it has a level 4, for instance, the 3, I think it's 3, 4, 5 are the numbers that you can start to feel really good about. So we'll make sure that you're aware of those tools as well. But I was really pleased to see that there's something out there helping us to guide us through all of this, because there are new therapies, new modalities all the time. And then the last thing I wanted to mention while I was thinking about it, and then I'll go on to some other things, is just hearing again about that family piece. I just think it's so important. So I have an 11-year-old son. And all pity me right now, right? And so we're starting to see some of the tween stuff, and so I've been trying to figure out how to work now to avoid getting to the inpatient point, right? And every little bit of research that I've been doing just comes back to that point. You have to be involved. You have to know what your child is doing. You have to know if they're being cyberbullied. You have to know if there's stuff going on at school. And so I just think that, in my personal opinion, one of the reasons for some of those numbers on those graphs and charts is because we as parents are so time constrained. We're so stressed. So I'm doing some of these tools and this research, and it says you need to spend 1 one-on-one time with your kid doing what they want to do, not checking your phone, not being worried about something else. And I was like, I can't do that. I don't know how to do that. I'm always multitasking. And it was quite a wake-up call. So I'm not sure how to take that and put it into practice, but you guys are working with families. You might see some of these things, particularly as you're starting to do some of this early identification. So it was something that was just a big light bulb for me, is that we're asking more of our kids and we're doing less with them. So anyway, so a couple of other things that we wanted to make you aware of in terms of behavioral health efforts that we're excited about. There's just a lot of really exciting stuff going on right now. So in addition to that SIM planning project that I mentioned, the Utah Bureau of Health Promotion is working on not only a behavioral health integration type project, but also care coordination. So it's bringing all of these things together. And so some really interesting things are starting to happen there, and we'll keep you informed as we develop and we see some results from that work. Mentioned the trauma-trained providers effort. And then I think you guys should have received an email, or many of you anyway, from us about the videos that the Med Home Portal has been doing. So as I listened to Cameron talk about the questions that you should ask, I realized we probably have a couple more questions that we should be asking on these videos, but I think that we asked a lot of those. And so this would be an opportunity, if you can't talk to somebody face-to-face or don't want to for whatever reason, or on the phone, that you could come to our YouTube channel. And so far we have 9, and they are largely in the kind of Salt Lake Davis area, because that was easier to bring them to us or go to them and do the video. But we're planning on expanding that. And so we have a series of questions that we ask them that really ask what kinds of modalities they're using, what are their techniques, inpatient, outpatient, those kinds of things. So we've got anywhere from medication management at the psychiatry level to kind of individual treatment that's very behavioral based, and evaluation in the range of folks that we've got videos on. And so we will be adding to that group of videos in the future, and the idea is to give you that opportunity to get more into the weeds of what they do, because we recognize how key and difficult it is.
There's 9, but will there be a lot more?
But a lot is a relative word, so I was really surprised in how much time it takes to put these on. But yeah, we're going to continue with, if we have resources, we will continue to expand on that. We want to see if we can use some kind of technological-based tools to do more rural providers as well, so that we can do a little video with them as well.
Does it kind of include their insurance and things?
It does. Yes, it does. You ask that question, but you have to remember that could change 5 minutes after the video goes through. So that's, I think, our biggest single challenge, is understanding, and so that's one of those other questions that I think is really important for whether it's the family or the care coordinator or whomever to ask of that potential provider. So unless you just know that this is what they do, I think that's something that changes so rapidly, it's really hard to keep our finger on. All right. So wanted to remind you that we will be meeting in December, because our meeting date falls early enough in the month. We decided let's go for it. We're putting together what we think will be a fun meeting that will productive as well as very enjoyable. So we'll definitely have a holiday theme. And so we hope you'll make sure that that's on your calendar for December 16th. It will be here, and as Gina mentioned, we'll be in the bigger room just directly south, so we won't be so cramped, and that will be wonderful. And so more information on that agenda will be getting sent out. And then watch for our Resources of the Month email. We'll try and get that out by Friday. That will include information on using our new forum tool. So if you want to connect with folks in between meetings, that was something. I'll say, and I apologize about this, that if you're going to register for an account on the Medical Home Portal to do your list, that is a separate account from the forum. Eventually, I hope to bring those together so it's all seamless and really easy, but there you would have to have 2 accounts, and I'm so sorry about that. But we're working on it for you. So I think that's it, unless anybody has anything else they want to mention before we call it good. 3 minutes early. Okay. Thank you, guys. Have a nice